Lovely, thank you. So I think I've appeared on here before, Sandra. I was talking about another project that I was involved, which is around advanced clinical practitioners working in primary care with a cancer specialism. And this project actually rolled out from that because when we went out to primary care networks to see if they were happy to host a pilot, they sent us a lot of kind of information about what they wanted to achieve from a cancer perspective in their PCNs. And that really made me think about actually a lot of that doesn't need to be done by an advanced clinical practitioner, and made us think a lot more widely about these new evolving roles within primary care and how we can utilise them better. So basically, it's an 18-month duration project. We're just coming up to about a year now. We're working very closely across the Cancer Alliance with other programs of work, because the funny thing about this is it fits into everything really: personalised care, primary care, education, early diagnosis. So we're working very closely. And then obviously there's a lot of work going on around kind of education around the Ascend program, which is a aspirant cancer career education and development framework, and all the work that goes on with Macmillan, and also the Prosper work, which is around rehabilitation and rehabilitation of cancer patients. So from this project perspective, what we've developed, and that's what I'm going to show you today, is a toolkit. So it's a cancer toolkit basically for this workforce, but it is basically aimed at the post holders in these roles, but also the employers of these roles. So there's lots of resources within it, which I'll show you to help kind of think about how these roles are utilised, lots of things that might help, like job descriptions, things like that. And then there's obviously the resources for the actual post holders. We've very much aligned it to what the cancer care priorities are within primary care. So that's around delivering the DES GP contract, the quality outcome frameworks, and very much working to providing personalised care planning throughout the cancer pathway. So from the perspective of the additional roles, if they're not something you're aware of, I'm sure you are if you're on this call, but they're very much separated into support roles. That's your care coordinator, social prescriber, health and wellbeing coach. You've got your assistive roles, nurse and associate, and pharmacy technician. Now I need to update this because we've got the GP assistants, which is obviously a new role that's included in the DES. So I'm just looking at that role at the moment. So I haven't put it on my toolkit yet, but we will be shortly. And then we've got the clinical roles. So physician associate, dietitian, occupational therapists, paramedics, FCP physios, mental health practitioners, and clinical pharmacists. So if I can go to the next slide. So drivers to this, obviously we've got the primary care drivers that we've already discussed, but obviously a big driver of this is we want to improve the care for people affected by cancer. We wanted to offer new opportunities for the additional reimbursement role post holders. And we think a big part of this is we're growing knowledge within this workforce will actually work towards a more integrated care pathway between primary, secondary care. And we're already seeing evidence of that in some of these roles. And obviously, they can play a massive part in tackling health inequalities. Next slide, please. So I've put this slide on here because I just wanted, I used this for another conference presentation I was doing, just to think a little bit about what it means within a PCN. So I went through a PCN of about 40,000 patients, and of those, 1,400 will be living with cancer. But what does it mean when we start to break that down a little bit further? Well, 350, so 1 in 4 we know will continue to face poor health and disability. And you can see on that right-hand side that, the biggest problems are around chronic fatigue, sexual difficulties, mental health problems, pain, urinary problems, gastrointestinal problems, and experiencing lymphedema. So these numbers are just to really show that within a primary care network, there is a lot of issues going on with our cancer patients. And I wanted to kind of be able to show that there is potential for, improving knowledge and skills in primary care to be able to deal with those from a non-clinical and a clinical perspective. We need to start thinking of cancer very much as a long-term condition. And particularly if you look at kind of the fact that 966 people have a cancer and one other long-term condition, that holistic management of these patients is becoming even more important. Now, some of this data, unfortunately, I will send it to you, Sandra, but because I copied and pasted this slide, I haven't actually got the pieces of research that this comes from, but I will send that on to you so you can share it with these slides. But if you look at people with one or more long-term condition, 242 will visit a GP or healthcare professional more than 10 times a year with cancer. And that was a massive difference to those that didn't have any other long-term condition. 261 of them will also be prevented from working in their preferred occupation. And what we do know is that there isn't enough support for cancer patients to perhaps kind of, get back to what they were doing before, or potentially thinking differently about what they do. So having a new type of expectation about life and positively moving to a different point or a different career. So looking at where we're going to be as well, if you think about it being a condition that affects largely over 65, so 60% of those people will be over 65. Over 50% of them will be aged over 80. And what we need to think about that, how does that relate to frailty as well? So 80 to 89 years, 30% at least will be clinically frail. So certainly as an alliance, we're definitely thinking about, how do we manage frailty and cancer and what does that mean? And potentially we could do a lot around kind of upskilling that generalised workforce, because we've got lots of frailty teams within primary care now. So that's kind of an area that we really want to investigate more and promote. Next slide, please. And also, if we think about what the projections are for primary care, so these projections were done quite a long time ago, but we are kind of speeding up to 2030 now. And when you look at that, you'll see that there's going to be a massive growth in the area of, people living more than 5 years with cancer. So that really is going to be a primary and community care focus. So I think that again really kind of provokes that thought and think about how we need that wide MDT within primary care to manage, cancer as a long-term condition, supporting, reviewing, self-management, promoting those healthy behaviours, symptom management and late effects. And then with that comes the palliative care responsibilities. That's an area that primary care are very much responsible for, especially in that non-specialist area. And I think there's so much potential for some of these roles to be very much involved in a proactive management of palliative patients within primary care. And then obviously what's coming is the fact that, 1 in 5 older people, is it 1 in 5 older people in the UK will be living with a cancer diagnosis by 2030, but also older people, 73% of those people will be older, very complex, very frail, and very multi-morbidity. So we're just needing that complexity of knowledge within an advanced practice within primary care. Next slide, please. So as I said before, this is the toolkit is there to be a resource for additional reimbursement roles. And what I will say, although that's obviously how we've been funded to produce this toolkit, a lot of the resources within it are absolutely useful to nursing colleagues, be it from practice to advanced level nursing. So we will probably be changing how we kind of show the toolkit in the future, so we're encouraged to make people aware of that they're getting that resource as well. As I said before, it's also a resource for employers. So we very much try to think about how we can kind of how we've tried to make sure that we can really show and demonstrate to primary care just how valuable these roles are and can improve kind of cancer care for their population. And then I won't lie, it's been a really great experience for us developing this toolkit, speaking to primary care and showing it, because we've been able to learn a lot about the opportunities that are available. We've been able to share best practice and communicate what's new and learn about the workforce needs. Next slide, please. So I'm not going to go into this too much, but I did put it in here just in case anybody wanted to view it in their own time. But obviously, just want to kind of highlight what we expect the outcomes to be. So improved cancer care provided in primary care, really kind of promoting that wider workforce that's able to support cancer patients, improving the pathways for cancer patients, definitely improving the rates of self-management by using those kind of social prescribing roles and health and wellbeing coaches, improving knowledge, skills and attributes to manage cancer patients. And from our perspective as an alliance, we really want to grow that cancer workforce and think about the opportunities for careers and career progression within primary care as well, and reducing the health inequality. And we are testing that kind of proof of concept for innovative roles within primary care across our alliance, which hopefully I'll come back and talk to you about another day. And next slide, please. Okay, now I don't know if you click on that link whether it will work or not. If it doesn't, we might have to unshare so I can take you through the toolkit.
I don't think it'll work from the
It
link.
won't. Okay,
No.
so if you unshare, then I will. Okay, hopefully you can see that okay.
Yeah, I can see it.
Brilliant. So that's all live on the Wessex Cancer Alliance website. So anybody can view that. So I will put a link in the box in a moment to go in there. So it's under the primary care drop down box there. And as you go into it, you'll see there's a quick introduction, and then each one of these roles has their own button. So if we go into the cancer care coordinator, there's several drop-down boxes depending on how much you know about cancer care coordinators. If we click on that one, there's just a nice quick short synopsis of potentially points of the pathway that you can use a care coordinator and think about them for your cancer patients within the PCN population. So we tended to keep at different points of the pathway: prevention, screening, safety netting, early diagnosis, personalised care. And I have to say, the more this role is kind of evolving in our region, this needs doing again. There's lots more we can add into there now. There's a next drop down box is what will this mean to patients? And certainly we're seeing evidence of this from talking to cancer care coordinators now, that it's really, really valuable having somebody as a point of contact within the surgery that's there for them, that can signpost them to who they need to speak to. It's not new news, is it, that patients really like that consistency about being known who to contact. There also been a great link to the other members of the MDT within primary care with assistance with that pathway as well. Now, the next drop down box is the place where the cancer care coordinator would go for all their resources. So in that, there's an induction package, there's a competency framework. It links them in to our kind of education series that we've done. We also run a regional community of practice, but we also get our cancer care coordinators to join the national one that Sian Lambert does. I don't know if any of you are aware of that. If you're not, I'll link you into that as well. And then we also make sure they kind of sign up to our primary care newsletters. So I'm going to just click into the resource and training package. So this was developed by Tamsin to basically have a resource that you go into to be able to start the job. Basically, it should have everything really there that you could start your role as a cancer care coordinator. Now, as the job is very varied, you may be working very much in the pre-diagnosis, But what we're finding is that quite a lot are working in the post-diagnosis, supporting patients after they've been diagnosed. So you can click on to wherever you want to go to. There's really kind of great practical resources. Say, for instance, where you might want to learn how to run reports for screening, etc., as well as, for instance, learning about where the awareness campaigns are, because lots of our care coordinators are, say, for instance, running the kind of awareness things within each practice. They'll go around and make sure that all that documentation leaflets are there so that that's ready to go for patients to see when they're in there. So it's very varied what's in there, and we've gone right from prevention to end of life with lots of training and education. It links into Menny Macmillan, cancer research, Guy's Academy. So lots of resources in there to take them further and progress them in their knowledge and skills. And then what we have on the next drop-down box is where those employing a cancer care coordinator or somebody who's thinking about it. So it links them into obviously resources we provide for the cancer care coordinator, but it's also got things like job descriptions, job adverts, sample interview questions. What we do have here, and this may be of interest to some people that are on today, this links out to a wider document that I developed that helped to look at all the drivers within primary care, the QOF, the DES, the long-term plan, and related them to each points in the pathway of a cancer patient, and then what those roles can do. So say, for instance, if we looked at early diagnosis in the contract DES, that's there. So one of the things we'd need to do was be educating on the risks and signs and symptoms, and that would need to be done for patients, non-clinical roles, clinical roles, and who could be involved with that, or all roles at appropriate level. But then if we looked at screening, uptake, contacting non-responders, then that could very much be done by cancer care coordinators, nursing associates, social prescribers, and it just gives kind of ideas, but use of, say, for instance, safety net and use of risk assessment tools, training up paramedics, MSK physios, physician associates in those skills. That's quite a big document, so I'm not going to go much through that, but if you would like to just look at that for a bit more information, you're welcome to. So that gives you an idea, and obviously each button has the same. From the perspective of the resource pack, the cancer care coordinators got their own, whereas the other non-clinical roles such as nursing associates, social prescribers, health and wellbeing coaches, they've got a shared document. And then the clinical roles have got their own shared resource document to go to, which is obviously points them to a lot more kind of management of symptoms, kind of acute oncological presentations. So some of that's knowledge based, some of it's forwarding on to different kind of training that's offered across many different sites. So that gives you an idea of what's in the toolkit. Now, from the perspective of being able to use it, obviously you can view it. I've talked to quite a few ICBs and other alliances who I've said I'm more than happy for them to develop their own in relationship to what they want to do in their area. They've either signposted to ours, because most of the stuff that's in there is generic, so can be used by anybody, but they might want to develop it so they can put their own kind of bulletins in and community of practices and things like that, which we're more than happy to do. But if people do that, it's just nice to know that they've done it so we can report that back when we report on our stuff. And then if I can go to the next slide, please. So I thought I'd talk a little bit about the cancer care coordinator role, because that in particular is one that we have very much been promoting across our network at the moment. And it'll be interesting to hear from other people that are on this call if that's something they're promoting. I know that in some areas that they're promoting this role mainly for social prescribers to do, but also kind of as time goes by and I have more interactions with primary care, I'm seeing that it's fitting in to other Rs in the sense of digital care coordinator roles or GP assistant roles. So requests are coming for kind of looking at those roles and potentially bringing that in and seeing what they do for cancer patients. So as you can see, there's a very varied amount of things that cancer care coordinator can do. What we're seeing at the moment across our patch is that they are very much kind of being embedded across all of those areas at the moment. There isn't one that they aren't. We're seeing that they potentially are being very much in the personalised care area of things. They might be supporting cancer care reviews. We've got a few that are actually involved in more the palliative care end of things. So arranging those GSF meetings, coordinating their care, signposting on. So it's quite varied how the role is being utilised, but it is being taken up quite well across our region. We have 20 in the Hampshire region, Hampshire and the Isle of Wight, and we have 4 over in Dorset at the moment. So anybody wants to kind of discuss that later or contact me outside of this, I'm more than happy to speak to how that's going because it's been a really successful role. Next slide, please. And what I wanted to kind of discuss, just the cancer care coordinator role, because that's the one we've got the most input with at the moment, is how this fits into integrated care. And I think very much so is what we're seeing. They're very much the point of contact to all of these other things. So if you think about the patient, as we've discussed, you know, it's somebody to go to. But what would be fantastic is if we could really do this at scale, because then we'd be able to go to secondary care and say, do you know what, there's a point of contact in each PCN that you can go to that then can signpost you who you need to speak to, because we also know that it's problematic for secondary care to get to speak to who they need to within primary care. From a voluntary care perspective, they're certainly referring and signposting out a lot to voluntary care, but we are seeing that referral back into cancer care coordinators to further kind of book appointments for patients if needed to see a GP. And then we are seeing that there's a lot of support system happening from the point of view of supporting patients' carers, making sure that they're referred, making sure that children are looked after, just making those kind of real, you know, needed things and being very proactive so that patients can complete their treatment without other stresses adding to it. And then what we are seeing also is that primary care MDT. So we are getting cancer care coordinators referring them to health and wellbeing coaches and social prescribers, and a lot earlier in the pathway. So it's improving that process and access to care, just really enabling you know, the whole pathway to work a lot quicker than it is. And we are seeing referring back out to cancer nurse specialists as well. And I think that's